Welcome to the Hematology Case Scenarios, Part 4. In this module, let's look into certain types of anemia and the importance of blood indices in diagnosis of the morphological types of anemia. First case, a 28-year-old man presents with worsening fatigue in the last 6 months. The history reveals that the individual was on prolonged and rigorous treatment with antibiotic for a bacterial infection. On examination, there is marked pallor, no icterus, no edema, no lymph node enlargement. Renal functions are normal. Hematology values: RBC reduced 1.8 million, hemoglobin 4.8 grams per deciliter, hematocrit 16%, WBC 3000, platelet 14,000. There's a pancytopenia as you see. All cell counts are reduced. Reticulocyte 0.1%, MCV normal 88 femtoliter, MCH almost normal 27 picograms. Blood picture normocytic, normochromic. Let's look at the question. Which of the following is the most likely cause of the individual's clinical state? Clinical state is anemia, severe anemia with hemoglobin of nearly 5 grams. Sickle cell anemia is out of question. There is no evidence of sickling. Bone marrow depression is the most likely cause. Erythropoietin deficiency, unlikely because renal functions are normal. Erythropoietin is secreted from the kidneys. Severe iron deficiency anemia, no indication of iron deficiency. The blood picture is normocytic normochromic, not macrocytic hypochromic. And blood indices are normal. And deficiency anemia, blood indices will be affected, MCP will be reduced, MCH will be reduced. So pancytopenia is the bone marrow depression, probably because of the drug-induced, antibiotic-induced bone marrow depression. That's the answer B. Second case, 50-year-old man is admitted for management of mild jaundice, low hemoglobin, and low hematocrit values. Which are the sets of following lab tests indicates that the anemia in this case is hemolytic type? So a set of lab investigations out of that: MCV, MCH, blood indices, reticulocyte count. Hemolytic type is characterized by the normocytic normochromic picture. Unless the blood loss is very chronic, there will be reduced. Otherwise, the reticulocyte count will usually be raised. So let us see which one. MCV decreased, increased. No, this is only in chronic blood loss. MCV reduced, MCH reduced, reticulocyte count reduced, increased will be chronic blood loss with iron deficiency. MCH decreased, MCH decreased, reticulocyte count normal will be in iron deficiency. MCV normal, MCH normal, reticulocyte count increased. This is typical of hemolytic anemia. So C, MCV is increased, MCH increased is not hemolytic, that is macrocytic. So C is the answer. Most of the times hemolytic type is characterized by normal blood indices, but reticulocyte count is increased because of the increased rate of erythropoiesis. The breakdown is more, so there is an attempt to increase the erythropoiesis by erythropoietin secretion. So that will be the answer C. Case 3. Which of the following sets of blood indices suggests maturation failure and ineffective erythropoiesis due to dietary folate deficiency? So folate deficiency is another cause of macrocytic or megaloblastic anemia. B12 deficiency we have seen in other molecule. Both of these deficiencies, vitamin B12, folic acid deficiencies, are characterized by maturation failure, where there is DNA synthesis affected, mitosis of the developing RBCs will be reduced, bone marrow shows ineffective erythropoiesis, and severe anemia. In this case, what are the blood indices? It's very obvious. MCV is increased, MCH is increased, MCHC is usually normal. Decrease, 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 unlikely. Decrease, decrease, normal, also not. Normal, normal, increased, only hemolytic blood loss. Increase, increase, normal. Yeah, MCHC is normal here because both MCV and MCHC are increased. Therefore, the hemoglobin concentration, hemoglobin as a percentage of the volume of the RBC is reduced. MCHC is different from MCH because MCH shows the absolute hemoglobin content in picograms. It's about 29 picograms. That's the average RBC content 29 picograms of hemoglobin. Whereas MCHC is hemoglobin as a percentage of the volume of the RBC. It's about 32% or 33%. That means 32% of the volume of the RBC is occupied by hemoglobin. When the volume is more, hemoglobin is more. This is what is happening in the macrocytic anemia. RBC is larger, they contain larger hemoglobin. The absolute volume is more, absolute hemoglobin is more. Therefore, MCHC will be normal. Even in that case, only 33% or 32% of the RBC volume is occupied by hemoglobin. This is D is the answer. So one should know the difference between MCH and MCHC. Confusing, but one should understand. Case 4. 46-year-old woman has uncontrolled type 2 diabetes mellitus. DM is diabetes mellitus. Her plasma creatinine is significantly elevated, hemoglobin 8 grams per deciliter. So she is in the early stage of, or in the renal failure stage, most likely to develop anemia that would be characterized by erythropoietin deficiency, of course. High reticulocyte count? No, this is not hemolytic or blood loss. Low erythropoietin level? That is a correct answer. B. Decreased red cell fragility. Usually in hemolytic, this type of anemia, kidney disease, red cell fragility not affected. Red cell fragility may be affected in macrocytic anemia and certain hemoglobinopathies. Increase MCV is unlikely because normally blood index is normal in the erythropoietin deficiency anemia. So B, low erythropoietin level, very obvious. Case 5. Anemia of chronic blood loss such as in menorrhagia would be characterized by a fall in which of the following? Menorrhagia is excessive bleeding during the menstrual flow. Menstrual loss is excessive. Months together the woman is losing blood. So there will be obviously iron deficiency because of the loss of iron after bleeding. Which of the following will be reduced by a fall in which serum transferrin concentration is transferrin is the iron binding protein. Protein will not be affected as such. Transferrin is an iron binding protein. There is a globulin, beta globulin. Tissue ferritin levels will be reduced because of the low iron content. This is the answer. Folate concentration will not be affected because blood loss doesn't affect the folic acid level folate. And binding capacity will be normal because protein is transferrin is normal. So it is tissue ferritin levels will be reduced in characteristically iron deficiency anemia. 6. Case 6. 6 months old infant is brought to the pediatrician for improper feeding. The infant shows pallor, icterus, hepatosplenomegaly. Blood picture RBC 4 into 10 to the power of 6 per microliter per million. MCV 60 femtoliter. Peripheral blood smear macrocytosis, hypochromia and poikilocytosis. Reticulocyte count is marginally increased. Hemoglobin electrophoresis shows little or no HbA, hemoglobin A, more of HbF and variable amount of HbA2. The likely diagnosis is of course very obvious. There is more of HbA, fetal hemoglobin, reduced hemoglobin A, This is beta thalassemia, very characteristic feature. Infant showing anemia, slight icterus because of RBC destruction, and a greater attempt at erythropoiesis by this stage by liver and spleen, hepatosplenomegaly, and there typically there will be macrocytosis, hypochromia because of the hemoglobin defect in the hemoglobin synthesis. This is a hemoglobinopathy where there is a decrease in the hemoglobin synthesis. The beta chains are not properly synthesized in the bone marrow. Beta thalassemia is more common than alpha thalassemia. Either may be affected. Hemoglobin has 2 alpha, 2 beta. So, beta thalassemia is a very common condition characterized by anemia in children. Fetal hemoglobin will be increased in this condition. You can see the hemoglobin molecules with 2 alpha, 2 beta globin chains with the heme molecules embedded inside the globulins. In thalassemia, the 2 beta chain synthesis will be affected. Case 7. 56-year-old patient receiving radiation chemotherapy. WBC count 1000, very much reduced. Platelet 40,000, very much reduced. MCV is normal, 85. Reticulocyte count is decreased. Peripheral smear shows normocytic normochromic cells with no abnormal form. So here is a condition where all cells are reduced, but size is not affected. So what is this condition? This is bone marrow depression, aplastic anemia. This is aplastic, aplasia. Bone marrow is likely to show aplasia. Hemolytic anemia, there should be an increase in the reticulocyte count if it's hemolytic. Anemia due to chronic kidney disease, there should be erythropoietin deficiency and other cells will not be affected. WBC platelet count will not be affected. Chronic kidney disease, erythropoietin is a typical growth factor for erythropoiesis. Folic acid deficiency, of course, it will be megaloblastic picture. Macrocytic cells will be there, hyperchromic cells. So it is aplasia, typical aplasia, very common after radiation chemotherapy. Case 8. 34-year-old man who is also a chronic alcoholic shows signs of malnutrition because of dietary preferences. Yes, food fats. Yes, glossitis. Physical neurological examination reveals nothing abnormal. Hemoglobin 9. Red cell count 2.3 million. Hematocrit 28%. WBC 10,000. Mean corpus of MCV is 122 is increased. 87 normal. 87 it's 122 large RBCs. Mean corpus hemoglobin is 39. 29 is the normal, 39. MCHC is still 32, we have already discussed, because volume is more, hemoglobin is more. So percentage of the hemoglobin remains the same. Hemoglobin as a percentage of the volume of the RBC is still 32. That means 32 volumes of the RBC is still occupied by hemoglobin. Deficiency of which of the following dietary factors must be the most likely cause of man's condition? Looking at the dietary preferences, you can say folic acid, because B12 dietary deficiency is not known, because we have a good, all humans have a good reserve of B12 unless the B12 is not absorbed by some other means. B12 deficiency by the dietary deficiency is very uncommon. Maybe in vegetarians only certain times, but very, very uncommon. You can select folic acid here. Vitamin C, there is no indication vitamin C deficiency here. essential amino acids, hemoglobin synthesis should be affected. This is a characteristic of folic acid. Iron deficiency can be ruled out because of the blood indices, folic acid.